This technique video describes a mini-open subpectoral biceps tenodesis using an Onlay knotless locking button technique. This case was performed at the Stedman Clinic in Vail, Colorado. Our patient is a 54-year-old right-hand dominant male who presents with right shoulder pain with persistent dysfunction after describing an acute tear of the proximal biceps tendon during recreational hockey game. On examination, he has a Popeye deformity with tenderness over the anterior medial upper arm, as well as weakness with forearm supination. He underwent extensive physical therapy and activity modification without relief in his symptoms. Standard radiographs of the right shoulder demonstrate no acute osseous abnormalities, whereas preoperative MRI demonstrates an empty bicipital groove with increased signal on T2 weighted imaging. Therefore, in the setting of persistent shoulder dysfunction with weakness and forearm supination, the decision was made to proceed with open subpectoral biceps tenodesis with a knotless locking button technique. A 2 to 3 centimeter incision is made just inferior to the inferior border of the pectoralis major muscle, which is easily palpated within the mid-axillary fold. Curved Metzenbaum scissors are used to dissect down to the level of the shallow bicipital groove in which the long head of the biceps tendon can be easily palpated. The tendon is retrieved from the open wound and the free end is secured with the hemostat. The tendon is cleared of any remaining synovial tissue and is secured with a high-strength suture at the myotendinous junction using a loop and tack configuration. This can be performed with either a needle driver or a scorpion suture passer. An Army-Navy retractor is placed laterally and a periosteal elevator is used to prepare the surface of the humerus for fixation. In order to maintain the appropriate length-tension relationship, the site of fixation should occur approximately 1 centimeter proximal to the inferior-most border of the pectoralis major tendon. A 3.7 millimeter spade tip is drilled in a unicortical fashion at the site of planned fixation. The drill bit is left in place while a high-strength suture is loaded through the nitinol suture passer of the locking button. The spade drill tip is removed and the locking button is inserted with the metal inserter. The black line on the metal inserter should be facing upward prior to flipping the button. The locking button is deployed by unscrewing the metal inserter in a counterclockwise fashion. The suture is firmly pulled to deploy the button and the metal inserter is removed. The high-strength suture is appropriately tensioned first by pulling on the single limb. The long head of the biceps tendon will reduce to the site of fixation. At this point, the suture can be cut and there is no need for a knot, as this is a completely knotless suture fixation technique.